When you ask me to think about a patient with myelodysplastic syndromes and transplantation, the one that strikes me in the last year was a young woman of 45 years. This patient has been lucky at the beginning with a Deletion 5q syndrome without any transfusion for a few months under hypotherapy, but rapidly after a few months, the patient became transfusion dependent. And this was a big hit for her to get transfused for the first time. So we began lenalidomide therapy with clearly some efficacy for 2 years, but after 2 years of treatment, the patient get transfused again. At that time, she had also some iron overload that get installed, and we began iron chelation therapy. And we had the patient to transplantation. She was lucky because she had a sibling which was compatible for her. And this patient has been transplanted with a reduced intensity conditioning regimen and is now at least 2 years after transplantation without any big consequences. She has been lucky not to have any real significant GVHD, no chronic GVHD, but only small acute GVHD. And she's now transfusion-free and really in a good shape after 2 years of transplantation. I think about this patient because she's really committed in the patient advocacy group of one of the French patient advocating group for myelodysplastic syndromes. And I think our story is a good example of what we can achieve for patients. And when we think about transplantation, even for patients that are maybe the less prone to go to transplantation with 5q syndromes, but this is really a success, even if, unfortunately, we can have this kind of success for all the patients. Any patient with myelodysplastic syndromes need to be considered for transplantation up front. Not all will bridge to transplantation because of disease, but also because of age and patient-related issues, comorbidities, for example. For the iron chelation overload and iron chelation therapy in transplantation, there's some evidence of an impact post-transplantation, but this evidence has been challenged recently with new studies and meta-analysis, so there's still a lot of work to do. The good way to evaluate the iron overload need to be complete and comprehensive, including both serum tests, but also imaging with echocardiography or MRI, and it's never an emergency. So you have time with iron chelation therapy in that case.